If I can ask you to take your seats, please, and welcome. And please take your seats, grab some food, and sit and enjoy.
That's great. Well, welcome everybody. It is a real delight to see you all here. And I think we're doing something very important for global soda care, and we're doing it together, which is so important. My role is small. It's just to introduce the people who are really going to be leading the show today. And my particular honor it is to introduce you, Elisha Dungiorgio, who is the CEO of the Global Health Council. And Elisha will be leading our show today. So thank you very much for being here and doing this.
Thanks so much, Gail. It's a pleasure to be here. And I always like to get applause before we start. That's always great. A good motivator. Well, good morning, everyone. Thank you so much for joining us for this very important session on the Operation Encounter Registry. It's great to see such a full room out here off the beaten track in early morning. So as Gail mentioned, my name is Elisha Dungiorgio. I'm the president and CEO of Global Health Council. And just a little bit about us, Global Health Council is a US-based membership organization, and we work on improving policies, resources, and programs for equitable, inclusive, and sustainable global health. We utilize the collective voice of our membership to advocate around these issues, both within the US and in multilateral spaces. To do that, we need data. And so that's one of the reasons I'm very happy to be here today. We need to do evidence-based advocacy, and to do that, we need good data, recent data, and widely publicly available data. Not only does this data help us to improve programs and services, but it really aids us in holding policymakers accountable for the promises they make in caring for patients and improving health and well-being of their citizens. So I've been asked a little bit to talk not just about Global Health Council, but about something called the Health Data Collaborative, which is a WHO-hosted initiative that GHC recently joined as a board member. And I just want to tell you a little bit about that because it's another great initiative to make a community of practice around readily accessible data to improve patient services and healthcare in countries across the world. So Health Data Collaborative was launched in 2016 following a summit around measurement and accountability for results in health and a roadmap for health measurement and accountability. There was a 5-point call to action that came out of this summit, and the Health Data Collaborative was one of the ways that was operationalized. HDC is a collective of more than 1,000 individual members and 450 organizations from a diverse range of stakeholders. And it serves as a platform to discuss the quality and use of data and how to improve weak and fragmented health information systems. So like the Operation Encounter Registry, HDC is another important piece of the solution to collecting solid country-owned data to help inform decision-making in health services, as well as policies and funding needs. So there's plenty of more information about this online, and I think we can share that. It's open to additional members. But today we're here to talk about the Operation Encounter Registry, and we have a panel of esteemed experts who are going to tell you more about the registry's data module, as well as the burgeoning community of practice accompanying the OER. I'm not going to read everybody's bio because it's an esteemed panel with pages and pages for each bio, and that would take the whole session. But you can see up here, we have photos of all of our participants, and there's a QR code you can scan to get more information about each of us. So without further ado, we're going to start with a short video to introduce everyone to the Operation Encounter Registry, followed by a series of presentations from our expert panel. And then we will have a panel discussion where we'll have time to take questions from all of you. So please hold your questions until then. I'm sure there'll be a lot of great information shared during the presentations, and we'll have time for a fruitful discussion at the end. So with that, I would love to bring up the short video. Can we get some help with the sound?
Determined to bridge this gap. Introducing the Operative Care Registry, or OER. This free mobile platform empowers healthcare workers to collect standardized data on surgical procedures. Imagine data sparking hope for improved surgical care. The OER empowers local actors. Healthcare workers collect and use data to inform decision making, leading to better treatment plans and resource allocation. The OER transforms development data guides health.
Just a moment.
Sorry.
Let's start. Yeah, I think we can. But I think perhaps we could do the video at the end. Okay.
We will do the video after. Please continue.
Okay. Can you turn sound so loud?
Yes. Sure.
Okay, so thanks so much. First up on deck is Dr. Terry Reynolds, who is the unit head of clinical services and the systems unit, the Department of Integrated Health Services, the World Health Organization. Welcome, Dr. Reynolds.
And I'll just wait for Claudio to get the slides up if we can. And I'm going to try to get up here, guys. We're a little bit pinned in, but presenting to you from behind our little triangle is a little bit odd. So just give us a second while we pull this up. And thank you for your patience. Yeah. Yeah, I understand. It seems to be, yeah. Is it okay now? All right. I will do my best. Just raise your hand and flag if it's not where you can hear me. Okay. So there's no way to not be turning my back to somebody, which is super bad luck, but let's try this. So I'm Terry. I know a lot of you in the room. Many of you in the room have contributed to this. So I'm always excited to talk about this, but I'm particularly excited to talk about it here because it really reflects the efforts of many, many of you in the room. And even those of you who are not directly involved, in many cases, have been indirectly involved in advancing this effort over time. This does not seem to work, but I can use your computer. So quickly, as many of you know, we have a stack of resolutions that provides a very robust mandate for our work in this area. It's been reframed in different ways over the years. One of the powerful foundational things, and I really want to take a minute to recognize that, is the one that was called Emergency Care Systems from 2007, which was the work of Charlie Mock, was the technical focal point at that point at WHO. The more time passes, so everybody knew Charlie, when he was here. He's a trauma surgeon. He's in Seattle now. But he did really foundational work. And this was the first resolution that kind of called for utilizing data effectively to actually improve care. And then it advanced over time in terms of our framing, but each of these resolutions calls for the use of data specifically to improve care. There's a lot of data in the world. Most of it is not actually defined or structured in such a way as to improve care. A lot of it can guide policy in a loose way, but it's very different to actually use data to improve care. So you see here some of the paragraphs that call for this. I'm putting them up not so we can look at them in detail now, but so that you have them later for advocacy purposes, because all of these make fantastic background for grant applications, for example. And then to give you a little bit more of the background that comes to this, what you see on the left, some of you, how many of you in this room know that book on the left, The Guidelines for Trauma Quality Improvement? Wow, okay, times are changing. Some of you know it. Often in rooms like this in the past, several people had actually taught it. So this is something that Charlie led the development of, and for many years, different surgical groups around the world, we kind of roamed around in different efforts, group efforts, and taught this course in countries. We looked systematically at what was inhibiting countries from being able to follow this guidance, because it's really fantastic guidance and talks about the mechanisms that allow data to make care better. But the biggest barrier that countries identified always, especially in low and low middle income settings, was the cost of a platform to actually do it, because the book suggests a number of things like preventable death panels, like M&M processes, like having a quality officer in a given department. However, and makes a very strong recommendation for registries, but that was the recommendation that most countries just couldn't follow because of the cost of a platform. So when we first started looking at this, when I took this, the precursor to my current job, 9 years ago now, we went around to countries and said, what do you need the most in order to be able to improve care? And they said, look, we can handle a lot of it. We have really smart quality people. We have nurses who've been OB quality officers for many years. We have a lot of capacity in country, especially from work on HIV. We know how to handle data, but we have no platform. That is a cost we're not even close to being able to manage. And they said, look, we get these offers from bilateral grants with high income country universities, but they're never sustainable. And they usually cause trouble with our laws about where data can be held, and the need to hold data in country. So in response to that, we created the WHO Clinical Registry platform. We can talk more about the platform in general, but it has a tablet form. It's built on a DHIS2 architecture, which gives countries a lot of control, because many, many countries around the world have a center with expertise. Many ministries even have a DHIS2 office. Now, traditionally, not to confuse things, DHIS2 is often used for very aggregate indicators of district health. It's actually rarely used for this indication, except in the area of NTDs of all things, but it's rarely used to hold case-based data. So when you talk to people about DHIS2, this isn't necessarily what they expect. But from all other functional uses, this is a very traditional web-based clinical registry. Any country can use it. They maintain ownership of their own data. WHO does not use their data or have their data. It doesn't get shared with anyone unless they choose to share it. And it's covered under, importantly, the legal data governance agreement with WHO and all member states. And it's held on secure servers inside the walls of WHO. And the idea behind this is a very powerful message: when data saves lives. So there's often this thing that I've been told about recently, this, you can't fatten a cow by measuring it. And it's a push to sort of, we collect all this amazing data, but we actually don't do the greatest job of closing the loop, of saying to countries, if you find a gap in this functional domain, already here are the options that have been successful at mitigating that gap. So in my mind, data should always be a closed loop process. Monitoring should already have a menu of possible ways to mitigate the gaps that you find. Now, those of you who do case-based quality improvement, that goes without saying for you. That loop is there, that's natural. But this message that that data should save lives, and specifically in certain areas, especially injury, this has been really evidence-based, that simply the institution of a trauma registry and some very simple process to create corrective action loops, that it can reduce mortality by up to 50%. So this is a really powerful story of when data saves lives. Now, sustainability is always an issue. Those of you who've done registry work, you know that there's a huge cost to dedicated data collection. You also know, if you know the literature, that the capture rates, when you're adding a data collection form to clinical process, that the capture rate actually is somewhere around 20 to 50 to 60%. That's usually what you get when you're adding a form. And it's almost never sustainable. So one of the things we've done, you don't have to use the registry this way, but one of the things we've done to support its use is created a standardized clinical form that has the embedded data points of the given standard data sets. So for example, the data set for injury. What that means is that a ministry can review and adopt this as its clinical form. It immediately improves care by guiding a structured approach to every person with an injury, especially in settings where there might be junior providers who are under-supervised or under-supported. This helps give them some guardrails. But importantly for this conversation, it has the data set for injury fully embedded within it and the data set for general emergency care. And then we have a very simple set of maps as to how you can extract from this form and enter the data onto the web-based platform. So that also removes the requirement that you have a clinically informed person doing it. And the capture rates, when it's done this way, are actually above or between 95 and 100%. because there's already a commitment in the clinical practice culture to clinical documentation. And this is not so much seen as extra. So that's one thing. This is the data set for injury, one of the existing data sets and modules that's already up there. Many of you know about this and have worked on this. These are the standardized clinical forms, and we've put these in so that you have them in the slides. This shows you how we map. So there's actually a set of slides that allows a regular medical clerk to extract. And there's a series of visual things that say this field on the form goes to this field in the registry. So it becomes just a simple mapping process. Now, the registry is built, and many of you participated in these early consultations. It's built so that it can be used out of the box for a country who this is their first use of any kind of clinical registry. They don't yet have a lot of familiarity and expertise. They can pull it out of the box and just use it as is. There's a series of buttons with standardized audit filters and also standardized visualizations. It also empowers first author papers from low-income settings, because we saw a lot of bilateral programs that didn't result in first author papers and research capacity building for the local team. So that was also a priority. So that doesn't mean where we got these was we did a literature review of all of the kind of reports out there from registry reports and said, we did a frequency analysis. What are the most common tables used? What is the most common visualizations used? But we also did a systematic set of focus group interviews with young researchers from around the world and said, what do you need? What do you want? What are the most important visualizations to you? And which audit filters are meaningful in your setting? So that's where the defaults come from. However, it can be changed, of course, to create new audit filters that might be particularly relevant. There's also some user modifiable fields. So that said, now what we're doing is adding to that existing platform this operative encounter module. So there are 3 or 4 different use cases for this. One is a country that really wants to look at its utilization of theater-based services. That's one simple thing. And so those countries might use only this module and just use it directly to understand what is the utilization of theater for them. It also helps them understand what's the balance of, say, elective cases and acute cases, what kinds of providers in terms of the surgical procedure and the anesthesia, what kind of providers are staffing what cases, and some very simple outcome information that would allow you to support at least simple audit filters. So that is one use case potentially. Now, there's another use case, of course, that people might want to combine it. And you can see the various data points here. People may want to combine it to do a full continuum of trauma care that gets more detail on the surgical procedures. And the reason it's called an encounter registry is that you may have more than one encounter. So the unit of analysis here is each surgery, not each patient necessarily, because you want to be able to capture every single utilization of theater, even if it's the same person. So other use cases might be combining it with the initial approach to an injured person. Now, we were just talking yesterday about interest in acute care surgery overall, so all surgical emergencies. And right now that could be done with the combination of the emergency care module plus the operative encounter module. So there are a lot of different use cases and ways this can be combined. This, many of you know, this is really, it's just an extremely important message, not for this audience, because you know this, and it's actually a problem how well you know this, because you have to really convince yourself that people don't believe this. So policymakers don't know what you know, and you have to get really good at expressing it explicitly and in simple terms, that this is where data saves lives. And you can have various stories about what happens. It's helpful often to have a narrative. This is a 35-year-old man. This was this person's problem. Here's what happened. Here's what was missed. Here's what can be recognized. Here's how we change practice. And here would have been the outcome in the world had we done this. And so connecting these 3 gears for policymakers and facility managers who have the power to do it is a very important part of what we do. This I mentioned quickly because this is one of our upcoming programs. And many of you have been working on this through the Global Alliance for Care of the Injured, and then will be increasingly through the Acute Care Action Network. But this is something called EQIP, which is basically the evolution of Charlie's work on trauma quality improvement programs. And this is establishing quality improvement programs in limited resource settings. And this is joint work with our quality team. And this is basically how to have a quality improvement program in a box, whether that is initially built around the registry, the clinical registry, or not. So one of the things that will happen with this operative encounter registry is as we roll out EQIP, which will be quite a high profile package, the operative care registry, the operative encounter registry will come along with that, and countries will be faced explicitly with the choice of implementing that module. And so what we found is a lot of times this is invisible, but if confronted with a question and a choice, countries will almost always take it to emphasize surgical care. So I'm going to stop here. The one thing I would say is this registry really has two goals at a policy level. One is to save lives, as we've talked about. And the second is to make the contribution. So the saving lives comes through driving quality improvement. So depending on who you talk to, you either just say this registry saves lives, or you say this registry drives quality, which saves lives from conditions XYZ. The big ones that get attention are injury, because it's the top killer of everybody age 5 to 29 and 9% of the burden of disease. Pregnancy-related complications. Those are big attention getters in the minister's office. But so you've got that this registry improves quality and saves lives, or you just jump the quality step, depending on who you're talking to. The second one, though, and this is for your broader advocacy community, is it really helps document the contribution of surgical and anesthesia care to the health system. So that is the other thing. This is an incredibly powerful advocacy mechanism to make visible what nobody's against it. Nobody's against it, but it is often not seen, and it is often left out of a traditional global health discourse. So that is the other goal of this registry. So I'll stop there. Happy to answer any questions.
Thank you. Thank you, Terry. That was terrific overview of both the clinical registry and how it links with the operative encounter module. Next, we have Dr. Neil Wetzig, Vice President, the G4 Alliance Permanent Council, Chair of the G4 Alliance Operative Encounter Registry, who is going to talk to us about the OER and the community of practice.
I will walk around here and use the computer as well. That one that says background. Okay. Just to make this clear, I'm presenting this morning on behalf of about 50 people across the Operative Encounter Working Group of the G4 Alliance. So while Chris and I are the honchos up front, there are many people been involved in this. So okay, so we've got computer problems.
While we're waiting to get that up, Neil is being modest. This is the result of literally hundreds, I would say, of weekly phone calls. Sorry, of literally hundreds of weekly phone calls for a while, and looking at every single data field and data point.
And at weird hours of the morning. And
At weird
depending on what
hours
part of
of
the
the
world I'm working on. Just while Claudio's bringing this up, just my background, you can probably tell I've got an Australian accent, but I actually work in the Democratic Republic of Congo. So this is quite personal to me about collecting data. That's where I live and work. And I want to show you a photo because this is really critical to it. The mission of the G4 Alliance is advocating for the neglected surgical patient, although some would say for all surgical patients. So if universal healthcare is going to be a reality, then primary healthcare has to be an important component of that. And the 1 in 3 people who need surgery, obstetric trauma, or anesthesia care within primary healthcare, they are the people that we need to help by collecting the data that is going to allow advocacy and, importantly, quality improvement, as you heard from Terry. So there's a photo I really want to show you, and if we can get this actually Okay. If we can get this working, there's a photo I have of a despondent young lady sitting outside a tent in an IDP, internally displaced people's camp, just outside of Goma, where I live and work in the Democratic Republic of Congo. And if she needs operative care, surgery, obstetric, trauma, or anaesthesia care, how do we provide that and how do we collect the data? Because that's what motivates me to do this. Terry's talked from the higher level. I wish I could show you this photo. Terry has already talked about, there we go. Terry. That's the photo, okay? Just contemplate that photo for a minute. That was taken a few weeks ago. That's a real photo. That's not something I got off the internet, okay? Terry's already talked about the various resolutions. And this road started particularly in the surgical field in 6815, back in 2015, about strengthening emergency and essential surgical care. Then we had the need to report the progress on that 2 years later. And then last year we had the wonderful ECO resolution. But each of these has had, and this is the wording from the 6815 resolution, member states are urged to collect and compile data on number, type, indications of surgical procedures and establish mechanisms to collect EESA case log data. Now we moved on to ECO, but the fact is that data still needs to be collected. The problem is that that's how data is collected in many parts of the world. That's in my hospital in Congo. Okay, it's all done by hand. Does that data go anywhere? Does it help with quality improvement? I can tell you I do not think it does. So I want you to dream, what if there was a mechanism to prospectively collect basic data on surgery, obstetric, trauma, and anaesthesia care? And what if this could be used, as Terry said, to improve quality, indicate where upscaling is required, and improve resources? And as we heard already, this may literally save lives. So this has been a key initiative of the G4 Alliance to work in conjunction with WHO to develop a minimum data set on a digital platform, and I'll come back to that in a moment, to prospectively collect data on SOTA care. And it's part of the WHO clinical suite of registries for advocacy, quality improvement, upscaling. Now, I love this definition because I want to get you excited about data collection. It's considered a very dry subject, but data, or data if you come from the US, is the compilation of 1,000 stories, okay? And if we collect data, we can tell the 1,000 stories of the neglected surgical patients. But surgery, obstetric, trauma, and anaesthesia care is often delivered in resource-poor settings. Again, I'm using my Congolese photos here just to demonstrate the poor resources. So as a working group, we've had to look at some guiding principles for such a minimum data set. Because if we want it to be used by all end users, including level 1 and level 2 health facilities, but also in high income countries, then we needed to have some principles. And I have to keep in my mind Dr. Makasani, who works in a rural hospital 400 k's from anywhere in Congo. This is a real doctor. He tells me he thinks about 12 operations a week, but he has no way of collecting that data. So how can he collect his data? He's not very sophisticated. So the data set needed to be simple, okay? And it needed to provide incentive. He needs to be able to say, to his Ministry of Health, I did this many operations. This is the breakdown of them. And his Ministry of Health needs to report. There needs to be interoperability with other centres where there is actually the ability to collect data. So you don't want to be entering it twice. And it needs to be, as you heard, de-identified information so that member states can report back to WHO. And it needs to be housed in a secure server. Now, just a little bit of history, because history can guide us where we went. So, as I said, the G4 Alliance formed a working group on this not long after it started, way back in beginning of 2016. And it was called then this terrible name, the Perioperative Case Log Database Working Group, which I could never get my mouth around, but anyway. And it went through 3 Delphi processes of about 50 experts, and it developed 38 variables. And it was piloted in a paper-based form in a number of countries. Now, the interesting thing there is on the bottom, 50% of the sites did not have existing data sets, but 100% of them said they wanted it. But it was paper-based, it was cumbersome, and it fell in a bit of a hole for a while. And we rejuvenated it in 2019. The original data set was reviewed, consultation with other groups that were developing similar databases. And this is just a smidgen of the groups that we consulted with. Now, most of these are research groups. What we're trying to develop is a facility or provider-based data set, not just for research. Yes, research will come out of it, but that's just some of the groups that we developed. Now, alongside this, over these last 9 years, WHO, as you've heard from Terry, has been developing the global clinical registries, and particularly the International Registry of Trauma and Emergency Care, and on a DHIST platform. So again, you'll hear a bit of crossover from what Terry said. WHO provides independent housing, secure WHO server. It integrates with the national DHIST registries, and it meets the reporting needs for WHO resolutions. So we've come up with a core set of 28 variables that Dr. Makasani can record in his rural hospital, 10 of which are new and were not in the International Registry of Trauma and Emergency Care. For centres that have a greater capability to collect data, there's an additional 10 variables in an extended set, 8 of which are new. Now, I'm just going to show you, this is the core set. The ones in red and bolded are those that we deemed as absolutely critical. So you cannot progress in the data collection if you do not put those in. And in a moment, Chris Dodgen, my co-chair of the working group, is actually going to run through the database with you. So this is just the preliminary. And then this is the extended data set that has some more difficult things in, primary source of payment. Dr. Makasani's not going to know what the primary source of payment, it's probably a cow or a goat or something. So that's pretty hard to put in a data set. So this is for slightly higher end institutions. We conducted a demonstration project in late 2023 in Pakistan and Kenya in particular, and we were doing a Latin American Spanish translation. This was specifically to test the feasibility of collection of the specific data sets. While we've been doing this in the last few months, the actual DHIS2 operative module has been constructed. The registry, though, will need to be piloted. That's the DHIS2 part, will need to be piloted. And that's part of WHO process. It's a good process. But we plan to develop something I want to introduce to you as a community of practice to support the pilot centres and then the subsequent rollout. Now, just a little bit of introduction to the community practice, and Natalie Sheneman, our wonderful advocacy manager for the G4 Alliance, is going to tell you a bit more about what the community of practice involves. In the demonstration project, there was obviously some problems with people had questions, not understanding the data set. So we set up a WhatsApp group so that they could contact Chris or I or Natalie or someone within the system, and you could get an answer fairly quickly to your well, we'd like to think it was fairly quick. We were in different time zones to the various questions you might have. Now, that's just in the small demonstration project we have. But once we go to piloting and go to the rollout of the DHIS2 module, there will need to be a community of practice, yes, to facilitate data collection, but there's this wonderful opportunity to set up a collaboration about soda care from people that are using the data. So this is a win-win. It's developing this community of SOTA practice that will run us alongside the registry. So I'm just going to hand over to Natalie, and she's going to describe a little bit more the community of practice. I'll be quite blunt about this. WHO has the module. It's funded through WHO processes. The server and everything else is WHO. Where the G4 Alliance comes in is we need funding to develop the community of practice, because that is going to be what makes the data collection successful. And it's also going to be what sets up really a community of people who are interested in the SOTA care and might have questions. I've got an example of it. We've set up a WhatsApp group for rural doctors we're training in Congo, and they now WhatsApp into us about when they have issues. They're on their own. The biggest thing I hear from them is we've got no support. They can now contact us, and we're able to give them advice, and we've seen lives saved through that. So that's where this community of practice becomes very important. It's also something that's going to be costly because we need people to run that. But Natalie, thanks.
All right, I'll just take over from here. And so that I don't have my back to Terry and Elisha, I think I'll sit here and maybe I'll ask you to advance the slides. Is that okay? Okay, thank you, Claudia. So first I'm going to talk just a little bit about G4 Alliance, and then I'll talk about this community of practice. So thank you. Neil already referenced the different variable sets that we use to put together to draft the variables that are included in the Operative Encounter Registry, and the organizations that we reached out to as part of that process. And I think I would just want to share that really something like that is only possible through an organization that has a big network like G4 Alliance. And we were able to essentially, we wanted to know who else was collecting data on surgical care and what was the scale and scope and the goals of that data collection. And essentially through word of mouth, we were able to reach out to these, and you can advance the slide. So we started with our G4 Alliance, Delphi and pilot that Neil talked about. And then we started doing some exploration to find out. We wanted to be sure that this tool was going to have acceptance, because everyone is kind of interested in this space and doing important work. So we were able to, through word of mouth, reach out to these organizations, the African Perioperative Research Group, contacting the College of Surgeons, COSEXA of East Central and Southern Africa, that's been working with RCSI to create a surgical logbook, some important research data sets at Stellenbosch and University of Cape Town, and then eventually working with WHO on integrating with the International Registry for Trauma and Emergency Care, which is now part of the WHO Clinical Registry. And so we were able to make contact with these folks who were doing important work and had developed these models of surgical care data collection and bring all of their insights and variables as part of this new tool. Next slide, please. So G4 Alliance is an advocacy organization that is committed to quality, safe, timely, and affordable care for surgical patients. So because of that, we're really invested in the success of surgical care data collection efforts. And for all the reasons that Terry shared, that there are these steps that happen, and ultimately it's about improving care for patients. So in conversations with our colleagues at WHO, Terry and others, about, once the tool is built, how do we ensure that that gap is closed, that we close the loop on both the collection, but also the utilization of that data? And the idea of the community of practice was recommended to us, suggested to us. Because sites will start to use this tool, and they'll need not only the tool, but the resources to implement it. So you can advance the slide actually. So this community of practice is kind of the answer to that. And it's a good fit for G4 Alliance because we are this network, we're already a community, and it kind of starts with our members, but it really expands beyond our members. So as I said, this is a good model for us. So basically the way the community of practice would work, you can go to the next slide, is that G4 Alliance would help to form those pilot sites that we've been talking about, putting together the different partners, resources, both technical and financial resources, to set up some pilot sites. And as sites, and sorry, you can go to the next slide actually. And at the same time, we would launch this communication platform for registry users to interact with the sort of support staff that would be coordinating the pilot and all the partners that are involved. So then all together, next slide, this would form the community of practice. You can go to the next slide. As sites begin to gather data, we would start to learn about the challenges, similar to in our small demonstration project. We'd start to learn about the challenges that they're having, the practices that they're developing around their data collection, and the kinds of insights they're getting from that data. And then what kind of resources they're going to need to make improvements at their facilities. As we learn about that, we'll be able to start connecting them to the resources that they need through our community, because G4 Alliance is not just hospitals, NGOs delivering direct services, but we're also professional societies, and then all those connections that we have through our network. And a lot of those resources that sites may need already exist. There are, guidelines for improving certain areas of care, best practices tools for doing integration with their electronic health records. But some of those resources may need to be developed, and we can learn about what those needs are through the community of practice. Over time, as we grow the community practice, we want to be bringing in new partners and adapting the services that we're offering. And eventually, once we're no longer piloting the tool, we really see this as a sustainable way for G4 Alliance to continue to support the Operative Encounter Registry and be involved in its success in the long term. So I'll just close with a final slide. Today, we are standing next to our friends at WHO, introducing a tool that is a very important big step in improving surgical care and surgical through data collection. But alongside the tool, we're also building an engine for change. And that engine is the community of practice, and we hope you will join us.
Thank you. Thank you so much, Natalie. And thank you, Neil. I didn't get to thank you, but that's okay. And next, now we're going to have a brief demonstration of the functionality of the OER led by Dr. Chris Dodgen, who's the Assistant Professor of Surgery, the Division of Trauma and Critical Care with the Medical College of Wisconsin, and also, as Neil mentioned, co-chair the G4 Alliance Operative Encounter Registry.
Thank you very much, Claudio. Can I get the opportunity to share my screen?
Yes, please.
I think this will be a little bit smoother than me coming over there. So 1 second. Let's see that this works.
There you go, Chris. You should be able.
Maybe. Reasonable. All right. Excellent. Ministers, colleagues, friends, donors, thank you very much for coming today and showing such an interest in the importance of collecting high quality surgical data. I really appreciate you being here and really hope that you learn a lot today and get energized as we were when we were bringing this to fruition. Nice. Right. My job's going to be relatively a bit easier in that both Terry and Neil and Natalie have done a great job kind of setting up the OER and the concept and why sort of we chose to use the DHIS2 platform, the value overall of being able to collect data in this way and make it widely available. It's able to be collected from a mobile device, a tablet. The goal overall was with the end user in mind. Again, trying to improve the quality of surgical data and the tracking of surgical data with the end user in mind, because realize that not many places have money for surgical data collectors. If this is not useful to the end user clinician to track their own cases, as Neil mentioned, to be able to get an idea of what their case log might be, what their overall outcomes might be, then that's going to be more difficult to collect. So bear with me. I am going to try and do this as a live demonstration of what it actually looks like. There. Ooh, small. A bit better? All right. Right. So this is what it actually looks like. So this is the practice environment is not yet published, but we hope to have it be published soon. There is a registry ID of the patient identification number. You can select sort of a core, the extended data set. That's the initial set of 28 variables versus the extra 10 added on. I'm going to go ahead and select extended now. A lot of the variables we ask if the data is known, because that is helpful as well in terms of quality data collection, knowing do we have a gap in not knowing or collecting the appropriate information, or do our patients potentially not know it? So for example, we can select that the age is known in the extended, thank you. In the extended data set, we do ask date of birth. That's not in the initial core data set. You can see on the side here, there's little stars. These stars mean that these are the required variables. And what this is telling me here, highlighted in red, is that I can't advance without entering some sort of age into this field. It won't let me sort of submit the information. The other demographics are relatively straightforward. We do then go on to ask sort of operative trauma versus not trauma. Again, this is the idea of integrating these registries. As Terry mentioned, it's not absolutely necessary that you adopt the ERTEC or the trauma module, as well as the operative encounter module. But if you do, this is one data point that can help you kind of link that information. Again, you're going to collect detailed trauma information through the emergency care or trauma module. And then that operative data, or that trauma patient who goes to the operating room and you want to find out more information or collect more information about their operative care, this allows you to kind of link up to that and track it. Additionally, we thought it was critically important to know if this is a primary operation or a reoperation. Again, this is a quality improvement initiative. So we want to know, are people going back to the operating room after their initial operative encounter? If it's a planned reoperation, as maybe in a trauma case where you left somebody's abdomen open, you go back and re-explore them to do the definitive surgery, versus an unplanned sort of complication operation. So again, focusing on that type of information for quality purposes. We do track or ask the patients where they're from. So in the basic form of the core data set, that's the general location of their village, their city, their town, their district, their region, what type of information we happen to have. In a extended data set, there's an increased functionality, and why this is the extended data set is it does require internet access to be able to enter it. As mentioned by Terry earlier, all of this data can be collected offline, and the system stores that data and uploads it when you do have internet access. Again, with the idea that this can be used across the world with variable rates of technology and internet connectivity. If you do have direct internet access, then you can click on this button. It pulls up a map. You can type in wherever you would like. Let's see. This is where I'm going next. Type it in. It pulls up a map. You could say, oh, okay, in Addis, I live on that street. You set the coordinate, And now that patient's location or area is mapped. And this is going to help significantly when we talk about sort of delays to care, right? So we're talking about access to care, being able, whether patients can be have adequate transport times, whether they're able to sort of afford to be able to get to care. This type of mapping functionality above and beyond the city, the town location, if it's available, will significantly help us determine the overall availability of surgical care worldwide. We ask about the type or source of payment, sort of the various different types sort of listed here. One key piece, and many of our variables have this, is we ask about an additional source of payment. So we mentioned sort of primary source of payment. We think maybe that's government insurance. And then is there a secondary source of payment, or if government insurance only pays up to a certain cap, then you can select the rest is going to be self-payment. So there's options in the database to select if you have additional data to enter. So we try to allow for multiple levels of data entry when it's needed. So number of prior facilities, this gets it, is there delays to care? You can enter in, if it's one or more, it will, if the internet is working well, it should pull up. Oh, there it is. So the referring level facility, this is where did the person just come from? So again, trying to get at the idea of where are the resources available for surgical care? If this person is maybe coming from a tertiary hospital, maybe from a quality standpoint, you need to look at that tertiary hospital and see if you need to expand if the surgical capabilities of that hospital, for example. We have basic date and time information, comorbidities that allow for some element of risk adjustment. We do have indication for surgery as well as the surgical procedures. We ask for categorization for the indications first and for the procedures that are being done. And what this allows us to do, again, thinking about ease of data entry. So we have about 103 surgical indications in the database. There's about 133 different surgical procedures that are in it across about 15 different categories. So the categories you can kind of see here. But what you can do is you select general surgery as your category. And what that allows for is there's a list of only about 15 or 20 that's easy to scroll down through. So you can decide, okay, this is maybe a perforated viscous, but maybe it wasn't just a perforated viscous. You have an additional indication. You click yes, I have an additional indication. It allows you even to select a different category. So this is quite useful for trauma operative cases, for example, right? You might go to the operating room, you get a craniotomy, you get an external fixation, you get an exploratory laparotomy. You can enter all of those in the same overall surgical encounter. It is an encounter level database, as Terry mentioned. So that means, again, it's based on the times you go to the operating room. So during that whole hospital encounter, you may go to the operating room multiple times, and therefore you will have multiple entries into this data set. That is linkable by that patient ID number. So you can track the overall episode of care, but because we are tracking overall intraoperative complications, as well as sort of the monitoring used intraoperatively, it needs to be that particular operative encounter episode. We do ask about sort of urgency of care. What you'll note is wherever we could, we included the definition for these variables to make it more straightforward for those data entry folks to understand exactly what they're collecting. If it needs more clarification, there's a little info button that you can click on. It provides more detailed information about the data definition, again, to help with ease of understanding exactly what we're asking for and make it standard. We get ASA functional status score to, again, look at the overall kind of risk adjustment and how sick patients might be. Just pull up sort of surgical intervention category. You have to select category of surgical intervention first. And then again, this is that sort of larger list of operations that occur. You can enter multiple operations. We ask about the type of provider, both the surgical provider as well as the anesthetic provider. And we don't ask for specific provider identification information. And we think that's critical. With the goal of this, again, is to improve quality. We want to be careful, and we're very conscious about trying to make sure that this is, while trackable and usable for quality, it's not identifiable at the individual provider level that would then potentially discourage the collection of adequate or truthful information. We ask for the type of anesthetic provider. You can select multiple types of anesthetic provider. One of the key quality pieces is the surgical safety checklist used. And actually, the next presentation, we'll talk a little bit more about that and the efficacy of this database to capture that particular information. We ask about general disposition after leaving the operating room. So was the patient alive or dead? Did they go, were they critically ill? Were they stable? And did they go to the ward? General postoperative diagnosis, did that match up with your preoperative diagnosis or indication for surgery? We do ask disposition. Again, was the patient discharged? Were they alive at 24 hours after surgery? And then ultimately when the patient is discharged. So that gets you kind of that ultimate outcome type information that you can link up to the quality of care that's provided. I'm going to go back to my slides, theoretically. Thank you. And all right. So I did plan for the lack of technology and availability. So I'm just going to scroll quickly through some of the slides that I prepared that I just was able to walk through. I can make these available. It does list sort of all the quintessential variables, et cetera. I talked about sort of the payment information. Next is that visual and analytics. One of the other powerful things about this tool is, again, we want to make it usable. What that means, and this was introduced by Terry with the trauma module, is that there are things set up in the data collection system to make it easy for you to track and understand your data. So that means for the demographics, for example, you can output your data as a CSV file, and it automatically is formatted to fit sort of your classic table 1 for a research paper. Your basic standard visualizations, and we're looking to characterize the cases that are being done, characterize the workforce, what quality improvement targets might you have. Some of those are listed here. So what type of anesthesia you might want to know. What's the disposition after 24 hours? And so all of that can be mapped out. And just by a click of the button, you can know what that looks like for the last month, for the last week, yesterday, et cetera. So it's very great functionality for being able to track your own information and have that right at hand. There are multiple different display options. You can display it as a chart. You can display it as a graph. There are standard audit filters that I think Neil mentioned. Some of them are listed here, though this isn't the comprehensive list, but we want to know about failure to rescue, right? The number of patients that had an intraoperative or perioperative mortality in a really low risk patient, that patient with an ASA class of 0, any mortality in a C-section, greater than 1 prior facility, and then in an urgent case, for example, those might be quality targets or things that you want to identify, those particular cases that stand out that are different. That then allows you to run an audit filter that's already built in. That pulls up this list of patients that is flagged as having met that criteria, and that allows you to do more of a deep dive into that data. So you can figure out where's the quality issues within that particular case and how do you fix the system. The final thing I'll mention is there is definable user roles within the system. So what that means is your access and your view at the hospital level can be different than that of the Ministry of Health. That is helpful because the hospitals and the individual providers who are entering this data need more detailed information. The ministry needs higher level information. Maybe they're going to want to aggregate the data at a regional level or at a national level in terms of what cases are being done, et cetera. And so that type of functionality can be built into the system and allow for, again, somewhat a protection of that more sensitive data or sensitive outcomes, but also allow for national aggregate information to be able to make estimates and overall national policies to improve surgical care. As Neil mentioned briefly, this is a work of a army of individuals, some of which are listed here. This is not a comprehensive list, but I did just want to mention, again, we happen to be the folks that are lucky enough to stand up in front of you and really argue for this, but it wouldn't be possible with all these folks and the hours that they put in and the time and the collaboration and the guidance that we've gotten from our colleagues at the WHO. So thank you very much.
Great. Thank you so much, Chris. That was terrific. Next, I'm going to ask Dr. Almas Katak, who is the Assistant Professor of Community Medicine at the Northwest School of Medicine, Peshawar, Pakistan, to walk us through a quality improvement through a demonstration project in Pakistan. Dr. Katak.
Thank you. Hello, everyone. So I'll be presenting the quality improvement example of use from Peshawar, Pakistan, from Northwest General Hospital and Research Center. So I'll tell you a little bit about the organization I work for. This is the hospital where I work, which is Northwest General Hospital and Research Center in Peshawar, Pakistan, and we were one of the sites for the demonstration project. So Northwest General Hospital and Research Center is a tertiary care 600 beds hospital, providing full range of medical and surgical services, not only for patients from our province in Pakistan, but for patients from Afghanistan as well. The hospital is operated by a company by the name Alliance Healthcare, and the chairman of our company, Professor Tariq Khan, is present with us as well. Many of you know him. He's a very renowned neurosurgeon from our country. He's the chairman of the company, who also runs 2 600-bed hospitals. One of them is a non-for-profit, and a medical school, Northwest School of Medicine, and a nursing school, and an allied health institute, which runs 9 bachelor's programs right now. We are very keen on establishing international collaborations. We're working very closely these days with Humanitas University Milan, Italy, Erlanger University, Surabaya, Indonesia, and NIHR Group, Cambridge University, UK. And of course, we are working, participating very actively with the G4 Alliance. So how did we become part of the demonstration project? We started collaborating with the working group in July 2023 and participated in a 6-week demonstration project from September to October 2023 and contributed 271 operative cases from Northwest General Hospital and Research Center from Peshawar and Pakistan. Once the demonstration project was ended, we really liked the experience, and we really wanted to continue. And I requested our management to let us continue collecting the data, and because we already had a hospital management information system, which is a homegrown and which we can like manipulate and use it as we want. So we wanted to continue collecting the data, and we used the extended survey variables, as Neil mentioned, and integrated that into our hospital management information system. And of course, we kept providing feedback to the working group and kept sharing data with them as well. So I'll briefly go through the data we have collected so far and analyzed. Right now, we have analyzed 1,656 cases so far. Over the last 6 months, from November 2023 to April 2024, and this does not include the cases from May, because we did not analyze that data, and there are another 400+ cases. From November 2023 to March 2024, Feb 2024, you can see there is an average 350 cases per month. But you can see there's a sharp decrease in the number of operative cases in the month of March and April, which happened to be the month of fasting in our country. And surprisingly, this was the first time when I looked at the graph, like how the social and cultural factors can influence people's health-seeking behaviors when it comes to surgical care. So this was an interesting finding for us. This graph shows the total surgical case volume by category. So, of course, the most operative cases were from general surgery, 520, followed by obs and gynae, and then otolaryngology, then orthopedics and neurosurgery. The percent of urgent and emergent cases as per the OER criteria, most of the cases were elective, 85.56%. And the emergent cases were 3% and urgent were 5%. The percent of cases done with different anesthesia types, most of the cases were, of course, done with general with endotracheal tube, and then followed by spinal and epidural, and then general without endotracheal tube. Laryngeal mask was used in those cases, and then 7.66% with regional and local blocks. The percent of cases done by anesthesia provider type were, most of the cases, 98% were done by physician anesthesiologist specialist, and only 2% were done by the same provider who performed the surgery, of course, when local anesthesia was involved. So this whole experience of the operative encounter registry, it really it significantly helped us with our quality improvement initiatives. We never looked at mortality rate per month or 24-hour mortality rate. This was the first time we calculated after we analyzed the data. The 24-hour mortality rate came out to be only 0.48%, and mortality rate for all the 6 months for all surgical cases was 2.05%. And we compared our findings with the available literature. I came to know that in one of the NIH study in 2020, it mentioned that for surgical patients, the mortality rate per month, mortality rate is around 5%. So it was kind of motivating and encouraging for us as well that our mortality rate was way lower than what was acceptable internationally. And also it led us to activate our mortality and morbidity committees as well. So the main hospital mortality and morbidity committee, they made subcommittees for surgical and allied specialties to look into the factors that might contribute to the increased mortality rates. And another encouraging factor was the percent of patients who died intraoperatively. So none of those around 2,000 patients died intraoperatively because we see a lot of patients and they ask the doctors and the surgeons that what if I die during the operation? So now at least we have data to show to the patients that see we have, like till now, we don't have any patients died intraoperatively. Similarly, the average length of stay, we never calculated that for the surgical patients. And after this operative encounter registry data, when we analyzed it, came out to be 3.3 days, minimum 1 day, and maximum 2 months, which was 60 days. And I particularly looked into the few cases that had higher months of average length of stay, the 2 months, and one of the patients that had been with us for 2 months, and we looked at his file, and it came out that he had a very serious trauma, and he had been run over by a huge truck when he was sleeping under the truck, and it just ran over him. So it shows us how different kind of patients we can receive and how the hospital should be ready for these kind of patients when, of course, long stay is expected. The most interesting thing for us was the percent of cases with WHO safe surgery checklist used. When during the demonstration project, it was used only 54% of the cases. But now after we continued collecting data and we became more and more aware with the process, now it is the WHO safe surgery checklist is used for 100% of the patients. Same is the case with pulse oximetry and ASA functional status. It was done, but it was not documented. After this registry experience, now it is done and documented for 100% of the patients. Then average number of the rescheduled procedures per month, it came out to be 5. And when we looked into the factors and the reasons, so most of the patients, they were not fasting before the surgery. So that's why their surgery was rescheduled. And in few of the cases, there were issues with their payment arrangements or delays, which of course led us to rescheduling of their surgeries. And in light of that, our admissions office now have a patient and family education program established, and where they're guiding the patients regarding the payment arrangements and to guide them through consent process and during the pre, intra, and post surgical protocols. So 85% of the payments were self-payment in our facility, because we are a private healthcare facility, and up to 15% government and private insurance. So those the rescheduled cases were those which had issues with the government insurance they had planned for their surgery. One of the worrying finding was a very high C-section rate for us. Till now, we had not calculated that, but after the operative encounter registry experience, we came to know in our facility, it came out to be 62%. And when I compared with the WHO acceptable figure, it was, I think, 20 to 25%. So this came out to be very high for us, but we are looking into the factors which are contributing to the high C-section rate. And for example, most of the patients are registered and they with us, and they attend regular antenatal clinics. And we're going to see, till now we have not seen each and every case, but after I go back, we have to see each and every case, how many of them they attended the regular antenatal clinics at our facility, and how many of them just walked in directly an emergency or from anywhere else, to see what contributed to the high C-section rate. And of course, we are devising a plan how to approach our ops and gynae people to help us lower this rate. I have highlighted this in red, the average number of prior facilities and level of referring facility, because in our country, we don't have a very established referral system. Most of the patients, they just walk into the hospital, and they can just walk in for any kind of symptom or in any kind of tertiary care hospital. But we had around 100 patients that were referred to us, but not from our country, but from Afghanistan. So we are looking into to how to go about this. That's why I have highlighted this in red. So overall, it helped us, the operative encounter registry experience helped us in improved medical record documentation and targeted quality improvement initiatives based on the identified trends above which I mentioned, and improved surgical patient management and outcomes, which led us, of course, to improved patient safety. And of course, we are now using the data for internal benchmarking as well. So I really like this interesting saying, think global, act local. And we're really grateful to the G4 Alliance and to the working group, Neil and Chris and Natalie and Rick, of course, for providing us this wonderful platform to think global, and for helping us and motivating us to build our capacity to act local, and now to be able to help G4 Alliance to act global as well. Thank you.
Thank you. Thank you so much, Dr. Khattak. It's really interesting to see how this works in practice and some of the unexpected benefits. Next, we're going to hear from Professor Adrian Gelb. Oh, there he is. Okay. Thanks, Dr. Gelb. Professor of Department Emeritus, Department of Anesthesia and Perioperative Care with the University of California, San Francisco.
Well, Claudia finds my PowerPoint said hello. Thank you very much for including me or us at WFSA in this. My email address is at the bottom of the slide. Happy to hear from anybody with comments, suggestions, and at a distance, I take criticism as well. I just want to comment on the Utstein consensus, because it's come up earlier. Utstein Abbey is an abbey on an island close to Stavanger in Norway. It has about 36 rooms. It looks like an abbey, and I can assure you the rooms are still consistent with life in an abbey. Single beds, shared toilet and washing facilities. It's an interesting experience, but it does allow one to bring a small group of people together for a day and a half of discussion. All of the Utstein consensus conferences have been funded by Lærdal, who are based in Stavanger, and there've been probably about 50 now. It started with CPR recommendations, and the Utstein formula, which you can find in Wikipedia, is fairly simple in concept. Good science, education, local implementation results in improved survival. So we believe we've done the good science piece, and I'm going to share that with you. The education piece I'm doing right now to some extent, and I'll tell you about our first steps on the implementation phase. Conflicts of interest that aren't relevant here. And just a reminder that we bemoan the current state of surgical care in the world. It is going to get worse. This is some data from Statistica. And if one extrapolates that line, by 2030, they estimate that another 80 million surgical cases will be done. This doesn't include the 150 million we estimate that don't get their surgery. So if we think we're an overwhelmed workforce, 6 years' time, it's going to be worse. The Lancet Commission on Global Surgery, published in 2015, described the concept of national surgery, obstetric, and anesthetic plans, an integrated planning process, and the need for integrating all of that is important. Our politicians, and apologies if there are any politicians in the group here, love to open hospitals, but they often don't think about you actually need a workforce in that hospital, and the hospital actually needs to be positioned where the patients are. The Lancet Commission set 6 metrics as a high-level way of assessing the health of a surgical healthcare system that encompassed important components. So if you will, what I'm describing is taking the conversation we've had to a higher level, which is sort of a national reporting level. But it became apparent within a couple of years, probably 2-3 years, that there were problems with those 6 definitions. Inconsistent interpretation of the wording. There was no stratification included in those initial steps. And the burden of data collection, which we've been talking about so far, overwhelmed many, many systems. And so a few of us thought there was a need for a relook at those definitions. This is our leadership team, John Rose, who is sitting here in the second row, Justine Davies, myself, Janet Martin, who is somewhere around in Geneva. Oh, there you are at the back of the room, and Janneke Mellon-Olsen, that I jokingly refer to as A and the 4 J's. And if you think we've done anything wrong, please blame one of the others. Fundamental principles when we set out on this discussion was that metrics need to be accessible now. What can be done now or within a 2-year period, a limited time period? Metrics need to be comparable. When we talk about POMR, perioperative mortality rate, the understanding in Pakistan needs to be the same as the understanding in the United States, the UK, in Honduras, or anywhere else. We all need to be working from the same definitions, and the information in those metrics needs to be actionable. They need to be metrics that tell us about things we can work on or fix. So we established a globally representative, gender-balanced set of work groups for each metric. So there were 6 work groups, and then representatives from each of the work groups came together at Utstein Abbey to talk our way through these metrics. Work group breakout session, came back with a recommendation for any changes, then discussed by the entire group, and then a vote on how to move the definition forward. We collapsed the 6 indicators to 5 indicators. So we made the 2 financial indicators a single entity, and we refined the actual wording. And I'll show you some examples, but I can tell you that they are crucial in our opinion, the small changes in wording. But when this manuscript was rejected by the British Journal of Surgery, one of the reviewers said they didn't see any change in any of the definitions, which was interesting. There's a difference, for example, in a fractured long bone and an open fractured long bone. It's one word different, but it was fascinating, the perspective. I can tell you one of the other reviewers couldn't understand why you'd want surgery and anesthesia metrics together. Not sure where that individual works, but I do want to point out that for many people, as we've already commented on, these sort of metrics are just dry. This is just grunt work. But in fact, these are metrics that are fundamentally about safety. The core central component is perioperative mortality rate. Pretty crude index of how well one's doing, but it's a first step. And one can think about all of the metrics as having a safety component. Patients need to get to hospital safely. They need to be going to hospitals that have a sufficient workforce. It's crucial for patient safety. There needs to be sufficient surgical anesthesia, nursing, and other experience to make it safe. And patients also need financial safety. And if one provided all of that, we'd really have happy customers. Very recently, the WHO released the Patient Safety Rights Charter. It was released probably about 3 weeks ago. And I just want to draw your attention to the fact that those 5 metrics are in fact encompassed in the first 5 of these 10 patient rights. I was thrilled to see this. When I looked at this, when Neelam shared this with me, I thought, wow, we were ahead of this curve, or maybe some of us had undue influence on putting this document together. Here's an example of what we came up with. So, and I'm not going to take you through all of this detail. So up at the top, we have the original Lancet Commission definition, then our slight rewording. So in terms of workforce, instead of number of surgical anesthesia, et cetera, specialists, we've changed it to each of those groups of individuals. So a very subtle change. And then in trying to make this realistic and actionable, we split things into what can countries do within the next 2 years? Or what could many countries do? What could countries potentially do in 5 years? And what could countries do in some more idealized future for many of them? So that we had a progression from the most basic to progressive disaggregation and more data. So for example, in the US or the UK, much of Western Europe, for example, we're working on the far right-hand column. We have all of that data already and to some extent use it. But for other countries, start with the simple. It's per national population. And then you'd progress to per regional population as simple steps forward. This is an example of a perioperative mortality rate. And again, the progressive disaggregation. And the way we conceptualized it was that from a reporting perspective, the basic would be for global reporting. And the intermediate and the full data set would be for local and national use, so that there isn't an excessive burden on Terry's computer system. Yeah. And as our second Utstein process, we took it the next step, which was to develop metadata sheets to facilitate the data collection. And I chose, for better or worse, to model it on the SDG template. And I give a lot of credit to John Rose for putting these together. And we've created data dictionaries for all of these metrics. So we've created essentially the infrastructure for anybody or any group to go ahead and put together reports. And to prevent the data reporting to become overwhelming, we wanted to go beyond the original Lancet Commission's bellwether 3 procedures and include some disaggregation, but without being overwhelming. And the way we conceptualize it is this would be the sort of Dow Jones index of surgical care, a list of about 42 or 43 procedures categorized by large surgical categories. And then we also included in our grant fund funding for 2 feasibility studies. And I noticed that the G4 team have referred to their studies as pilot studies. These are pilot studies, but with the explicit intent of feasibility. I was surprised we had 18 applications. So there was a lot of interest in actually playing around with this. We picked 2, one in Ghana, one in South Africa. And it was an interesting exercise on repeating to them that it doesn't matter if you can't collect data. We're not actually really interested in the data. What you're being funded to do is to tell us, can you collect the data? And if you can't collect it, why not? Which is what they're doing. This is some of the preliminary data from our Ghana team, just categorized, color-coded, highly feasible, feasible, somewhat feasible, not feasible. Ghana actually has a pretty good infrastructure based on DHIS2, who were participants in our Utstein process. So that's a sort of crude overview of what the Ghanaian healthcare system can potentially do at the present time. A key aspect, previous speaker spoke about local and global. The way we see these metrics and the challenge ahead of them is getting from the local to the national to the global level. And then there's the question of where do these global national metrics reside? We currently have an agreement from the World Bank that anesthesia and surgery are included in the Human Development Index, but it comes with a requirement that we as a community need to provide them with data every 2 years. If we cannot provide data from somewhere in the world, anesthesia and surgery will drop out of the Human Development Index. And then there's the question of whether this is of interest to WHO as a place to report national data. We sincerely hope so. And that's it. Thank you very much.
Thank you. Thank you very much, Professor. I think next we have a video from Dr. Barrero. Okay.
Dr. Barrero.
Dr. Barrero's video. So we're going to see a short video from Dr. Barrero, former Vice President of Ecuador, and also a neurosurgeon and founder of the Latin American Health Corporation. And then we will turn to question and answers. Maybe I'll just ask a question, take moderator's prerogative. Claudia's teeing up the. I just wanted to ask the workforce question. And obviously you, Neil, Chris, Terry, you've thought a lot about making this platform accessible, simple, and easy to use. It does, however, still require time to use it and some behavior change, particularly for a workforce that may be switching from paper to electronic records. And so I'm just curious to hear a little bit more about what that time allocation looks like for workforce and what kinds of behavior change issues you're anticipating as you scale up the OER.
I'll lead off and Chris might want to add to that, but we've looked at this. It takes about 10 minutes, first of all, to complete. You should be able to do it on a iPhone or iPad, an Android, could be either, on some sort of tablet. And the reason that it means a whole paradigm shift for people that have been collecting data on paper is that's the benefit of the community of practice that we need to put in. But having said that, if you look at low and middle income countries, they are some of the highest users of mobile phones and tablets. They are digitally fairly savvy. So it really just means moving the needle from paper data collection to collecting it like that. And we believe that's doable, but the community of practice needs to build into that.
Just to add on to that, I mean, I think there are a lot of materials that are out there with regard to assisting with implementation of data collection, a lot of which comes from the WHO and their prior experience, especially with the trauma care registry and implementation, the cultural shift in terms of the importance of data collection, I think as a collective goal of the G4 Alliance, and hopefully most of the folks in this room, I know it's significantly important to our partners at WHO, and there are resources that, again, we hope to leverage through the community of practice, and the best, again, realizing that there are going to be challenges, but the hope is that folks come together and talk about those challenges and learn best practices from each other so we can sort of advance the whole process together.
That's great. I'm just going to ask one more question about this piece. And I know we had hoped to have a Minister of Health here, and we weren't able to do that today. But I'm curious about the role you see in this behavior change and the rollout of this new platform, and how it starts at the leadership level in country. Is that the Minister of Health? Is that someone else? Who do you need from the policy government world to help really push this platform?
Yeah, just to say, so we know a lot about, and actually it doesn't have to come from leadership. So it's completely intentionally a flexible resource. So we've had great success with champions in facility-based champions around the world. And for them, it's an incredible opportunity to raise awareness of their leadership. So sometimes it starts from that level. They collect data and they have then this very powerful advocacy platform to raise the profile of this issue with their own governments. Then in other countries, for example, in Rwanda, the registry was rolled out as the national trauma registry. And that, of course, is very powerful. But there is no way that it has to happen. What's fantastic is when you have a country who doesn't have this agenda, doesn't have this issue on their agenda politically, and then you get a few sites of individual champions. That's why you cannot underestimate the power of your constituency to change their countries and the world. You get a handful of sites that do this. They are able to feed that up. Governments love data and pretty digital platforms. And all it takes is a small handful of sites before suddenly this is an issue for the government. And then you go to the phase where it's disseminated top down. And we've seen all of those pathways. Great.
I was going to phrase that slightly differently, but quite consistently. In terms of the NSOAP concept, one needs to SOAP at every level. And so it's both federal, provincial or state level, and then at the local hospital administration level. And in my limited experience, many, perhaps most healthcare systems are very much devolved. And it's not a matter of national economy. Canada has one of the most bizarrely devolved healthcare systems I've ever encountered, where the provinces collect their own data. It's not always consistent with the federal data collection. Provincial ministries of health do dual reporting and data collection. But in concept, it's all consistent. And I think, as Terry alluded to, sometimes these things are probably led by the Minister of Health, but more likely they're led by other people within the healthcare administration. And as Richard Horton noted when he spoke to the WHO just pre-COVID, healthcare is a whole of government issue. And so it's not just about the Ministry of Health who need to be engaged, but crucially, the Minister of Finance. Without the Minister of Finance agreeing to changing the healthcare budget, it's lost.
Very true. Can I just ask Dr. Katak, since you've done this in country and you've done a pilot, can you just share your own experience with sort of the grassroots momentum to have this, become a more widely used system?
Well, we only practice that in our own facility, in our own hospital. And even in our own facility, initially, we did face challenges and issues. For example, the data collection. Initially, we thought that the operating room staff will be collecting the data, the nurses, or maybe the doctors, but it was a huge challenge for us. Like they say, like it's impossible for them to collect this amount of data every day for each case. So even in our own facility, we had to make alternative arrangements. We had to hire more people, and now, of course, data managers and research assistants to help us with the data collection. Once we started and people came to know about it, our colleagues in other hospitals, now they have been approaching us as well to make them a part of this process as well. So, of course, the people are ready, and the other hospitals they have seen and they have contacted us. So I think it's going to be taken up by other people quickly.
Great, thank you. And sorry, Chris, did you want to add something?
I was just going to mention that Adrian talked about sort of the disparate data that's collected at various different levels, whether it's the hospital, the regional health bureau, and they may not be the same definitions. The advantages, obviously, of this data set and the other WHO data sets is it does create that standard definition, those standard practices. So everybody is collecting the data in a similar fashion. And so then that makes it comparable. That's significantly more powerful than what we've had to date in sort of the surgical community. So that's one of the wonderful things about this.
I was just going to add a comment about the implementation piece. Many of us don't have very good understandings of implementation. In another forum, I talk about why implementation fails. And it fails mainly because neither we nor our hospitals actually understand that the implementation process is a little different from the process of collecting the data initially. And the implementation that works in Northwest Pakistan may not work in San Francisco. So each implementation is a new experiment on local climate. So the implementation is a huge, huge challenge and a different mindset in getting it to work. And so when we think about the implementation, it really needs a discussion and an experiment. And hospital administrators, in my experience, are not interested in experiments in data collection. They want to be able to say, Adrian, you know about this, get it working. And we saw that play out with collecting or implementing the Safe Surgery Saves Lives checklist. And I think what we failed in that process, many of us, is to understand that implementing something is totally different. And one of the crucial factors, it turns out, in implementation are processes like accreditation, which force behaviors, and standards from national societies. So those are two other groups we need to be looking to engage. Groups like the Joint Commission International, for example, all of our national societies to endorse collecting these sort of metrics using the tools we've been speaking about. So it's not just about the Ministry of Health, it's about using every available opportunity to bring pressure on hospitals, states, and national governments.
Thank you. I'm just going to, Terry wanted to do a brief response, and then I'm going to open it to the floor for questions. So go ahead, Terry.
Yeah, just a couple of quick things on implementation. We have a lot of experience with many different kinds of facilities, and there are some important commonalities and then some important context specificities. One of the things we're working on a project, Birmingham was mentioned earlier, but around a readiness assessment. So is your site in a state of readiness to implement? And what it does look at is a lot of implementation science factors. that are independent of the political commitment, independent of how much everybody wants this to work, and looks at whether what steps could be taken to make sure it will work in a sustained way. And I want to introduce Vanessa Naidu from our team who's here. Maybe Vanessa, raise your hand because she's coordinating our work on the EQIP. I mentioned the establishing quality improvement programs. Kind of program in a box, and that will also have, it's not the same in every setting, but the same questions need to be answered in every setting to evaluate. So it'll be part of that. One thing to flag also is that I agree that this incorporation into accreditation and certification pathways is very important. I'm not sure I would characterize it as putting pressure on the facilities. But I think there's two critical things. One is incorporating it into those pathways, and we are working with ISQA, the International Quality Organization, to look at how this might work, because they have long wanted to incorporate a requirement for registry, but it was never equitable to do so because of the financial cost associated with the registry. So they are very excited about this WHO platform that is free to users because it creates the possibility for them to then incorporate a requirement for registry into their thing. The other thing is, and this is the last thing, is just the most critical culture shift. You were asking about behavioral change in particular. Registries have to not be or be perceived as punitive or creating the potential to be punitive. And fundamentally, that means two things. That means a kind of system approach within the facility so that you're not M&Ming an individual, but you're looking at the system. And most of you know that. The other thing that it means, though, is so the local users own their data in this registry. It's completely free to them. But it is important that we set defaults in terms of what the ministry sees and what a facility sees. And you all know this, but it's really important to be explicit about it. Because if you just look, for example, at mortality rate, the hospital seeing the most complicated cases will appear to be performing the worst. So there are certain metrics that we don't automatically put onto the ministry dashboard. So we put, for example, death in low-risk patients to the ministry dashboard, because that's the kind of thing they should be acting on. And I know that sounds simple, but there are 3 or 4 moves that you have to make to avoid the possibility that a registry promotes a punitive culture. Yeah, so that's probably the biggest thing.
That's a really important, good point. I'd like to open it up. Why don't we take a couple of questions at a time? And if you have a specific panelist that you want to ask, we can do that. We have roving mics. I see a woman here in the second row. I'll start with you. If you can just say your name and ask your question.
Hi, everyone. So my name is Christine Garuya. I'm an emergency medicine physician and clinician scientist. I'm between Stanford and Yale in the US. I'm also an implementation researcher, and most of my public health research is in Kenya, where I'm from originally. But just a couple comments, questions. One was whether it's available offline. One of your core team members told me it's available offline. I think that's just key for the messaging because that wasn't inherently clear. The second piece was about your implementation process outcome on retention of training for using the registry. So I'm just curious to know, or hopefully just suggesting that you're also collecting that, because of course you train somebody and then either they forget or they leave. So just thinking about frequency of training as you implement the approach. And then just 2 quick suggestions for funding your community practice. One, there's an interesting NIH mechanism called an R13, which is a meeting grant. It's less competitive than a lot of other NIH mechanisms. So it's something that's interesting to think about. I think it's up to 100K at a time. And then the other pitch is to come to CUGH, so the Consortium of Universities for Global Health, as sort of like a touch point. I'm the co-chair of the research committee, and love to chat more in terms of leveraging the CUGH community for amplifying this.
Great, thank you. Yeah, let's take, okay, I see a lot of hands. So who has the microphone? Go ahead. It's a free for all. Go for it.
Thank you. I'm Daniela Filipescu. I'm the current president of WFSA, and I want to thank all the speakers for their presentation and the G4 Alliance and WHO for this great project. I'm convinced. I'm looking forward to implement this in my country. I'm coming from Romania, and I'm convinced that the way for quality improvement and saving lives is to have data. I have a specific question about rescheduling the operation. So I think, in my opinion, would be nice to know the reason for rescheduling the intervention. I attended last evening Global Surgery Foundation event, and I was touched by the example of a case in rural Nigeria where procedure was postponed for 6 months because of a device broken for that period. So I think it's very important to know if the reason of postponing the surgery is because lack of anesthesiologist or anesthesia provider or device or blood or whatever. And another suggestion would be to connect because I saw in the registry the post-operative diagnostic. So to connect this to ICD, what 10, 9, 11, because some countries are using this. Thank you.
Thank you. Let's take one more this round, and then we'll do 3 at a time. So one more in this round.
Okay. Hi, my name is Amy Verstappen. I'm the president of the Global Alliance for Rheumatic and Congenital Hearts. Our organization has over 70 member patient family organizations in over 50 countries, more than half of them in low resource settings and in virtually every setting that we discussed this morning. I also want to say that personally, I am a survivor of complex congenital heart disease. As I'm sure everybody in this room knows, 1 out of 100 births cause over 30% of infant mortality globally, and that is rising daily. I also personally have undergone over a dozen cardiac procedures requiring intubation. I want to first note just some specific examples of the way patient family organizations have not been key leaders in moving this forward. And I'll just give you 2 examples because I know time is tight. So, or 3. A Pakistan Children's Heart Foundation, which initiated through a connection we made involvement in a major registry globally, which many of you I hope know about, which is the International Quality Improvement Collaborative for congenital heart surgery, over 50 cardiac centers. Anybody can join, including NGOs, small NGOs. So Farhan Ahmed, whose child died of congenital heart disease, who started this foundation, both funded it, required it for all the surgeries that was done in the facility that he was funding, and then obviously worked directly with government. And this was adopted by the Pakistani government because they work in government hospitals too. The second example I will give you is my previous organization, which was the Adult Congenital Heart Association in the US, where we passed a law which mandated federal funding, where we got NIH funding to do registry work, and where we then basically certified centers as quality centers to treat patients like us. So when you talk about quality metrics and inclusion in accreditation. I have 3 questions for you, which is first the obvious question. I know different people are going to want to answer this. How can we ensure that we include cardiac surgery in this endeavor? Make sure those voices are here, because we're a big and growing population, and also include infant mortality, because I think that's really important. And specifically, I know you do it on the ground, but how do we get it in the advocacy space? Because that's what our organization does at the end of the day. We amplify those voices. The second is, how can we get transparency on the agenda? And I'm specifically talking about transparency directly to the patients and families. They have to make decisions. There are models of this. And at the end of the day, if you're not sharing that information with the people who are being affected, it's unethical. That is the US high income standard. And the third thing is we saw many pictures of patients today. My hope next time we get together is we won't just see pictures. it's sort of a basic right that the person themselves should be there telling their own story. So obviously, I hope that all of you will, we want to help. Our job is to help connect you with voices in your area, to help amplify the message. And I know that we all believe that basic human dignity requires not just those of us suffering from this to come and tell our sad story. That's the least important thing I've told you today. It's about using us and understanding that we are the drivers of change. So thank you.
Thank you. Thank you. Lots of good questions. Thank you for sharing your story. I'm going to start with the brass tacks questions around the module. And I'm going to ask Chris about this. Questions about availability of data offline, as well as retention training statistics.
Absolutely. Thank you. So available offline. Yes, it's available offline. That's partially the design of the system is you don't need internet connection to collect the data. And then as soon as you have online access, it will fully upload the most recent data that you've collected. So that's one of the beauties of that system is it is specifically designed for areas of low resource. You also asked about sort of follow-up and durability of training. I think that's an excellent point that we need to consider and incorporate obviously into the implementation piece of this. We are at the beginning stages of having developed this data set. We hope a lot of people in this room will consider early adoption, and we'll learn a lot from that process. But you're absolutely right that we need to follow up the education that goes along with the implementation of this work. I might pause there, though.
Can I just, while you're on the mic, can you also perhaps talk about the inclusion of cardiac surgery in the module, as well as inclusion of infant mortality? And I think there was a question about whether there could be more data around the reasons for rescheduling of interventions, or if that is maybe in the extended data set that we just didn't see in the module.
I promise those questions weren't plants. We have all of that data in the registry. So there is our cardiac conditions, congenital cardiac conditions is one of the both the indicators as well as the procedures that can be performed. In terms of, sorry, I just lost the other questions.
Cardiac surgery, infant mortality, reasons for rescheduling.
Thanks. Infant mortality, there's not this is not an adult only database. Age goes the full spectrum. And so this will give us data about sort of overall infant mortality. We have C-section as a procedure. You can look at sort of peri C-section infant mortality. Now, it's not going to get you sort of baseline infant mortality that's not associated with a surgical procedure, but it will get you a mortality in all sort of cases of pediatric operations. The 24-hour mortality, the discharge mortality, all of that information is collected. In terms of the question about the reasons for not being able to do a procedure, we specifically included that. So we talked about there's a variable that says the number of times that the case is rescheduled. And then if you have anything more than 0 there, the next question that pops up, it doesn't pop up for everybody, but if it's more than 0, then it asks why. And then it asks, is there another reason? And so you can check the box, yes, there's another reason. So you can list multiple reasons. It can be, and they're relatively broad categories, so it's not going to get you the 100% nitty gritty, but it's, was it patient factors? Was it financial factors? Was it system factors? Was there lack of anesthesia care, lack of surgical care? There is an other category for a lot of the variables that allow people to enter in data that we haven't thought of, because I'm certain there's things that we haven't thought of. And as this gets adopted in larger places or more places, we will learn from the collection of the data. There will be procedures that we haven't thought of that are drastically done more than we thought, and they aren't originally included on the list. So just collecting the baseline data will actually tell us so much more about the surgical care that's provided across the world, and we hope it gradually gets better with time.
I don't want to lose the question about patient engagement and using this data also to help inform patients or engaging patients in the development of systems like this. And I wanted to go back to Dr. Katak because you mentioned in your presentation development of a family education program after you had seen the data, I think on rescheduling interventions. Was there more in that? Can you just tell us a little bit about how you engaged patients after you saw the data?
So our facility is already seeking Joint Commission International accreditation. So that's why it was kind of easier for us to integrate it into our system and to implement it. So one of their requirements is patient bill of rights. So all the patients that get admitted in our hospital, we just our admissions office, they just go to each and every patient, and there is a QR code is also installed in each room, and they can write their bill of rights and whatever information they want to know. And also with the help of NHR group, we have established a community engagement and involvement program as well. And we have around 50 patients who are in that group. And with their help, we have established a community advisory board. And those patients, they come every month. We have scheduled meetings with them each month, and they come and they ask us different questions, and whatever information they need, we give to them. And of course, then they disseminate to their respective families and friends and colleagues as well.
Thank you, Dr. Katak. I'm so sorry. We're trying to figure out if we could stay over a few minutes or if people have to leave, and we're at time. And so I know some of our panelists have to leave. The week is very busy. So I'm going to give Terry 1 minute to say something, and then I'm going to return to Gail. And then if people want to stay after and speak individually with the panelists, you can do that. Unfortunately, we just didn't have time for your multiple questions, which I'm sure are excellent and would bring even more insight into this great platform. But yes, that's what I just said. Yes. Yeah. Go ahead, Terry.
Thanks, guys. Yeah, I apologize. I have to be inside the Palais by 10:30. And as you know, it's a little bit of a slow moving thing, but you have from our team, Vanessa and I do, who I mentioned on eQuip, and then Lee Wallace in the back, who many of you know. Just quickly, just to say thank you. This is really exactly how we like things to work at WHO. So there's certain things that really only WHO can do. And then there's a lot of things that we don't do well, that we're not structured to do. We're very good at providing a neutral platform like this. This is meant to amplify your efforts. So now if you get a $3 million grant from your National Research Council, instead of spending $2 million of that on a platform, we would like, and implementing at 5 facilities, we'd like to see you implement at 50 facilities and have a free online platform. So that is our kind of role, also providing a neutral common language. As Chris mentioned, like that's something WHO is very good at. Now, what we can't do ourselves is exactly what you're talking about, this kind of community of practice, this rollout. So I just want to thank you for all of the work together so far, and hopefully all of the work together that is coming, because I really see this as the optimal approach to playing to our strengths. And our job as WHO is to amplify your ability to have impact in countries. So this is an excellent example of that. Thank you very much for everything.
Thank you so much, Terry. And I just want to thank all of our panelists before we close out. And I want to just give the mic back to Gail to say a few words to wrap us up.
Great. Well, you've summarized very well. I think that we all agree that this is one of the single most important things we can do as members of the SOTA community to improve care, expand care through data, saving lives through data. It also takes money. So if there are any funders in the audience, please see us. When you go back to your respective locations, please seek funding and connect us with those funders. We want to make this happen, and good quality work depends on having some funding for it. And finally, I want to thank our sponsor. I don't know that I see them here today, but Professor Adrian Gelb mentioned quality through accreditation, and The founders of our feast today is a nonprofit called the ACGME International, the Accreditation Council for Graduate Medical Education, an international nonprofit, Chicago-based, who are very interested in seeing all of these efforts that we do trickle up and down into good quality providers of every kind of medical care. So thank you very much for coming, and let's go forward together. And say